Hi everyone, my name is Ashley, and today I'm going to be talking about attention deficit hyperactivity disorder, otherwise known as ADHD. So just a brief overview of where we're headed today. We're going to talk about what ADHD is and how it's diagnosed. We're going to go over a brief history, talk about some changes and trends, treatment, and ethical concerns. So as a refresher, what is ADHD? Well, ADHD is typically categorized by three behaviors: inattention, hyperactivity, and impulsivity. Inattention can typically look like not being able to stay on task, being disorganized, or having difficulty focusing. Hyperactivity usually involves excessive or inappropriate motor activity. So this could be fidgeting, tapping, or being overly talkative. Impulsivity usually includes impulsive actions that occurred without any forethought, so interrupting or darting into a street without looking. So in order for an official ADHD diagnosis to be made, for a child, at least 6 symptoms from the diagnostic criteria listed in the DSM-5 must be met. And again, those are hyperactivity, impulsivity, and inattention. For adults, at least 5 symptoms from each category must be displayed. And for all patients, it must persist for at least 6 months, and it must be inconsistent with the developmental level. That's usually in a child. So if the individual meets at least 5 or 6 of the criteria, then the clinician will also specify whether they are combined presentation, predominantly inattentive, or predominantly hyperactive impulsive. The severity of the condition will also be specified, with mild meaning that only moderate impairments to social or behavioral functioning are occurring, and severe meaning that there's excess symptoms required to make the diagnosis, and they also result in a major impairment to social or behavioral functioning. So a brief history for all of you history buffs out there. So ADHD has actually been around for quite some time, not in the same context that it is now, but it was first recognized in 1798 by a man named Alexander Crichton. He wrote a book called On Attention and Its Diseases. And then in 1902, the first case study was presented by a pediatrician. His name is Sir George Still, and he had documented cases of hyperactivity and impulsivity in children with those inattentive presentations. Then in the 1960s is when these symptoms really began to get traction in the clinical world, and then they were referred to as minimal brain dysfunction at the time. And finally, in the 1980s is when an official diagnosis was created for these symptoms, and it was indicated in the DSM-3. So over time and across the different DSM versions, the terminology surrounding ADHD has changed quite a bit. So in the DSM-3, it referred to the diagnosis as attention deficit disorder with or without hyperactivity. And the DSM-3 also required the onset of symptoms to occur before age 7 in order for the diagnosis to be valid. Then in the DSM-4, the diagnostic criteria changed again, and it changed to attention deficit hyperactivity disorder with 3 different subtypes that I mentioned earlier, combined, predominantly inattentive, or predominantly hyperactive impulsive. And another change in the DSM-4 was the recognition that these symptoms will likely persist into adulthood for most of these individuals. Prior to this, it was believed that ADHD was typically grown out of. And it's still believed that some of the symptoms will decline, especially the hyperactivity as we age. But the DSM-5 does make more of an emphasis that many of these symptoms will still persist into adulthood. And the DSM-5 also made another change to the age of onset, so now it's before 12 years old, after recognition was made that many of these symptoms don't manifest clearly until adolescence or in school-age children. So here we have a graph that I pulled from the CDC website, which talks about past and current data regarding prevalence of ADHD in the United States. So from 2003 to 2011, the prevalence clearly increased, going from 4.4 million to 6.4 million children. And then you can see in 2016 that it actually dropped down to 6.1 million a little bit. But the website does indicate that the formatting that they used for the survey was a little bit different, so the results can't be directly compared. But regardless, it's still safe to say that the prevalence of ADHD in children in the US is a very large and growing number. So based on that data from 2016, we can see that 9.4% of all US children have received an ADHD diagnosis, and that is equal to 6.1 million children. And now boys are 5 times as likely than girls to receive a diagnosis, and white children are twice as likely as African American children. So despite the millions of children that we see given a diagnosis, there still may be some diagnoses unaccounted for out there due to these ethical and cultural considerations. So from the 6.1 million children that have received a diagnosis, 46.7% have received behavioral treatment and 62% have been medicated, which brings me to treatment, which is often stimulants. So the first line of treatment, and oftentimes the only treatment used, is going to be stimulant medications. These are going to be from amphetamine derivatives like Adderall or methylphenidate formulations like Ritalin or Concerta. And stimulants are the most commonly prescribed medication class in child psychiatry. They're well studied, they're considered highly effective for short-term use, but there's actually ethical concerns regarding long-term use that I'm going to touch on in just a second. But a random fact that I wanted to throw in that I thought was interesting is that no new compounds or active ingredients have been introduced to the stimulant market for over 20 years. So there hasn't really been a lot of innovating going on. But there are a lot of ethical dilemmas regarding ADHD, and one of the biggest ones is medication use, especially over the long term. So this is the point that I want to kind of land on today and have you all start thinking about for Thursday. Since stimulant medications are often the first and only treatment choice for many clinicians working with ADHD diagnosis, there's often concerns from parents, patients, and even clinicians themselves about the treatment. There's a few viewpoints that I've seen argued in the literature surrounding medication use. And the first one is diagnostic accuracy. Second is risk of abuse or misuse. And the last one is the side effects and long-term effects. So oftentimes the accuracy of a diagnosis is brought into question. Since there's no biological test that can be conducted to confirm an ADHD diagnosis, a lot of people will question its validity. And some argue that the symptoms of ADHD can be considered within the normal range of behavior in children, and therefore ADHD may be overdiagnosed and stimulants may be overused. There can also be an increased risk of substance abuse or misuse. Studies are kind of all over the board with their findings on whether or not taking stimulant medication actually provides a protective effect or if it contributes to the misuse of substances. But there is substantial evidence to state that older adults or older adolescents and young adults are more likely to misuse or distribute their stimulants outside of a clinical use. College students are actually the most common group to participate in taking stimulants without a prescription. And the final dilemma that I want to present here are the side effects and the long-term effects of taking stimulants. So the short-term effects can include insomnia, decreased appetite, weight loss, GI issues, tics or twitching, headache, dizziness, cardiovascular complications, which can even lead to death, and other comorbid disorders. So for a lot of clinicians and patients, most of them, the benefit of taking this medication outweighs the potential side effects, but a lot of individuals can be highly sensitive and at greater risk for these side effects. There's even been some cases reported of sudden death in children taking stimulants. And additionally, the side effects of this medication may create comorbid conditions that require further pharmaceutical treatment that wouldn't have been necessary prior to starting stimulants. Previously existing or increased risk of comorbid psychiatric disorders also has to be considered when determining stimulants to be an appropriate form of treatment. And unfortunately, the long-term impacts of stimulant medications have been very understudied. There's a lot of contradicting and inconclusive evidence from the studies that have been performed. Results show that stimulants can both mitigate or increase the risk for mood disorders, substance abuse, and other comorbidities. And another concern is actually on growth impacts in children taking stimulants, since it decreases appetite as a side effect. But again, studies have shown mixed results stating that stimulants can either contribute to stunted growth or have no effect. The biggest issue is the lack of long-term studies conducted, and there's lots of areas that have little to no research. One of them is how stimulants can impact executive functioning in the long term, which I think is pretty important. But the biggest concern for researchers are the factors that are limiting their control of performing these long-term studies. One example I saw is that individuals don't stay on their medication for the entirety of the study, and so it impacts their control factors. But regardless, the potential for long-term risks associated with stimulant medications should be better understood so that patients can make the most autonomous decision for themselves in their treatment. So for Thursday's class, I want you all to start thinking about some of the ethical issues that I mentioned regarding stimulant medication and whether or not you think it's an appropriate treatment. Thank you everybody for listening to my presentation, and I hope you have a great day. And here are my references.